This interconnectedness adds an extra level of complexity, because one of the things that we are working on, and everyone agrees is broken but it's very hard to fix, is the interface between providers. So how do staff in different services communicate with each other? And at the moment, people in tech say, oh, there's no interoperability in healthcare. Oh, there is interoperability. It's called letters, right? Every single system handles a letter. Every system. The challenge with letters, even if you're doing them digitally, is, let's say hospital deals with actually thousands of GP practices. Each of those practices deals with hundreds of other providers, tens of hospitals, a whole range of community services, school nurses. So the whole thing's interconnected. And I genuinely think the communication between services, although at the moment it is the vast minority of the communication on our platform, I think quite quickly it could become just as, if not more valuable than the communicating with patients.
Hey everybody, today I have Jacob from Accurx with me, a man who pretty much needs no introduction in health tech, especially if you're in primary care. You definitely know what Accurx is, but making moves, making waves into secondary care, into pharmacies, into doing lots of stuff. So everyone in health tech is going to know who you are, Jacob. You're going to be famous across the whole sector soon. So how are you, mate?
I'm good, thank you, and very nice to see you. And thanks for the kind intro.
You're very welcome, mate. Well, it's sort of true, isn't it, that like I can remember when you've been on this a while ago, right? It's 5 or 6 years since you've been on this podcast, so a lot of water under the bridge. But Accurx, fair to say, known as what, like the darling of primary care, the darling of primary care technology. Like you burst onto the scene in just solving everyone's problem pretty much for free, and then got sticky, and everyone in primary care loved it, right? I remember there was like Facebook groups, just like everyone just saying, Accurx is amazing. It was crazy. It was crazy. Can you remember way back then? Can you remember all that stuff? All the hype, all the glory?
Yeah, I remember that moment of delight for practices. Hopefully not hype. But, yeah, because I think last time we spoke was before COVID. So
It was.
All we did was let you send an SMS message to a patient. And I always described it at the time as embarrassingly simple. And we kind of had to earn the right to do more complicated things. And for the system to be willing to receive that, which is definitely something COVID helped accelerate, which I'm sure we'll get onto. But I remember 2018 was just the sorts of stuff we were dealing with to get on a user's computer was like, their antivirus is blocking us, they don't have admin rights, their internet speeds is too slow. Do we send a CD-ROM out? It's 2017 or 2018 actually with the installer, which thankfully we didn't need to do, but it was a very heated debate in the office. Just to be able to send a text message. So it was like getting the real basics in place. Like, talk of AI was not even, you know, think I would be mad to talk about that when we're trying to get people to install stuff. And then I'd say in our roots, it was spend time with users on the ground, see the problems, and quickly build solutions. So we were lucky to, I can't remember, I don't want to repeat loads of stuff we did last time, but like the brief version is we started doing antibiotic prescribing. After 18 months, couldn't get anywhere. And then went and spent like 6 months living in a GP practice and doing all these different experiments. Loads of really cool impact, but most of them were completely unscalable because they relied on loads of change management. But two things. One, that's where we learned the value of just spending an irrational amount of time with users. And there's still the thing that keeps me up at night today is, are we spending enough time with our users? Because if we were building like Trello or Gmail, we'd just be using it ourselves. And so you just keep making it better and better. But we're not running a healthcare provider. And so we don't have that advantage. But then the second and even bigger thing we learned is this is all a communication problem. Like it would be, I remember shadowing a GP appointment, and a patient had an outpatient appointment, and they'd come into the GP and say, right, I've been told I need to start this new medication. The GP goes to look at their letters, and they're like, oh, nothing's come through from the hospital. Do you remember what medication it is? The patient's like, I think it starts with a T, and the GP's like, could it be this? It's like, how is this how healthcare happens? Or sitting in reception, and we just wanted to like learn how the practice ran. So we like went on Amazon, ordered these little like phone splitters so we could put another handset in. And you'd have like a paramedic calling out saying, I'm with the patient, and they've deteriorated in some way, but we don't know what their care plan is. We need to speak to their usual GP or find out this information. And then there's this panic in the practice of like, is that GP even in the building? Do they work today? Can we find them? Are they with a patient? So like, this is all a communication problem, like everything. And pretty much, well, not pretty much, entirely since then, since 2018, every single time we see a new problem, which is kind of like every minute, right, in a healthcare organization, you're like tripping over inefficiency, and not through any like sort of malintent or anything, or lack of hard work, just because it's a really complex system that's incredibly complex. I'm sure we'll get into why. Every time we do that, we look at it, it's like, this is a communication problem. It's like, right, we need to get patients out of hospitals on time. It's a communication problem. How do we make sure that we have really high uptake of MMR vaccines? There's, herd immunity. It's a communication problem. How do we make sure that, patients who are frail and at high risk of hospital admission have preventative interventions? It's a communication problem. And so that's what we've become obsessed with is solving that. Obviously, starting in general practice, like you say, which has been and continues to be a like very, very rewarding journey, because general practice is, they know their patients well. They're dealing with everything, like the sort of this massive undifferentiated demand. And if we can make their day that bit better by making it easier, safer, more accessible, it's incredibly rewarding. It's a massive, massive privilege.
You know what, mate? I can't imagine what it must be like for medical students now that do like a GP placement, and they go into their GP and they're met with exactly what you've just described, because they are still being met with that in so many places. But they've got the ability to go, well, ChatGPT can do X, Y, Z, and they are using so much technology in every other place of their lives, as is every junior doctor and probably GP and consultant now. That like there's this pressure building from all the technology that we're using, all the efficiencies that we're seeing across other areas of our lives, and yet you're seeing and feeling and having to work through all of those problems in a healthcare environment where you kind of just common sense just assume that everything should be better. And it's such a bizarre, I don't know, it's such a bizarre juxtaposition that you might drive to work as a GP in your Tesla, and then you walk into the place that's trying to save lives, and it's that chaotic, built on old technology and difficult to change. And it's funny actually when you talked about what the job actually was, and you use phrases like unscalable and couldn't touch it because it was too much change management. It's so interesting that like if a sort of analogy of like however battered a car is, at some point it just becomes a write-off. And you just wonder, like, you've looked at problems the same way. Like, there's a certain level of change management required, and you just like, do you know what? That's actually a write-off. Like, it's just like we almost need to leapfrog it at that point. Like, there's so much going on in a GP practice. Like, you're not short of problems to solve. If anyone's wondering what's my idea going to be, try just shadowing a GP for a week.
Yeah, so it's a few anecdotes. So I did an event a few weeks ago, and there was some GPs focused on using technology, and most of them have started their GP training in the last 5 years. And they have a lot of the observations you've had. But I was also thinking to myself, wow, this whole generation, they weren't GPs 7 years ago when you had to get out a dictaphone and say, "Hi James, I've reviewed your test results. Please call reception to book an appointment." Like they haven't. That's still how outpatients works, by the way, which I'm sure also we'll get onto. Well, one, it's nice that there's some progress, and it's nice that they don't even have to know about or think about that world, right? Because we've moved on across the sector. I think so I definitely agree with the, like, everyone's used to technology being more usable, more on demand, being more connected in sort of other parts of their life, and then we expect them to show up to work and basically turn that all off and become sort of go back 20 years in terms of technology. But I actually think, when I think about your example of medical students and the shock of, wow, this is how things work.
Yeah.
I actually think tech is a relatively small portion of that. So I remember at university, I lived with a medical student who's now a surgeon, and actually multiple medical students at university, and their shock at not just the tech, but the systems and like the pathways and the processes. Yeah. And I actually think that's far, far harder than the tech to change and to implement. And that's what we see a lot today, is like the opportunities, the things we're talking about aren't technologically complex, but they are very complex from a systems point of view and from an implementation point of view and a change management point of view. And I go around a lot in my head of this leapfrogging question. And I broadly agree, because what I find, in fact, I entirely agree, because what I find is so much oxygen goes into rearranging deck chairs, sticking plasters, local optimal, whatever you want to call it. Very well intentioned, like those are right things to do, but we completely miss the bigger opportunity. Now, I partly get that, and it's hard because the system is under so much pressure that they're like, what gains can we get, like, now, like today, let alone in this financial year, like today, what gains can I get? And the stuff we're talking about is not quick to like go and reconfigure how you deliver specialist care. So we're working on trying to find like what are the big and simple levers that have the biggest impact. But I think a lot of this goes way, way deeper than the tech. And I actually think this is why, if I look at why we were able to grow so fast with messaging, it was that there was zero organization level process change to make before you as a user get value. So 2018 was the year of how can a user hit our website and within 5 minutes they're messaging their patients. 5 minutes, because that's less than the time it takes to call one patient. So if we can get them set up to call many patients in that time, to message many patients, then they're already sort of in surplus in terms of the time that they've got back. But if I then fast forward to, in general practice, the thing that we know makes if messaging of patients makes a 5 to 10% productivity improvement, the thing that makes a 25 to 50% productivity improvement, which is running a total triage model, surfacing all your demand, triaging it appropriately, dealing with what you can asynchronously, that requires a change in how the practice runs and the expectations they set with their patients and the expectations they set with their staff on what their work actually is. Are they sitting and triaging requests coming from patients, or are they just doing appointment after appointment? The expectations on receptionists of like, is it patient gets in touch and you get them in an appointment, or is it patient gets in touch and you collect a sort of lightweight history that a clinician can use to triage? So that's the hard bit, but also that one, I would say to the team, like, the reason it's hard is the reason it hasn't been done before. So like we shouldn't shy away from that. But also, like, that's the really fun bit, is working out how do we change. If I think about now fast forwarding to secondary care, like outpatients, a small aside, we had a meeting at a hospital near the office, and Elliot, our GM for Accurx, and I walked over, and we walked past this building that was all boarded up, but you could see some old NHS signage, and it said it said outpatients department, and then there was another sign that was probably from like the 70s, they said Outspace Patient Department. And then in the brick relief, it was the London Hospital Outpatients Department, from like, over 100 years ago. I went to look up online after, like, what is this building? And I found the floor plans online of this hospital. And it looks like, when I show it to other hospital leaders now, they're like, yeah, that looks like my outpatient department, every outpatient department, as in like reception area, massive waiting room, consulting rooms around the edge, pharmacy on the way out. It looks incredibly recognizable. So where was this floor plan published? It was in the Lancet, published as like the gold standard of flow in an outpatient department in 1904. So this is like, Nye Bevan was 5 years old. Alexander Fleming was just starting medical school.
Wow.
The phone wasn't in widespread use, let alone the internet. Like the phone, it was 20 years before the phone was in widespread use. And like that's the model we run today. And so there's a lot of artifacts of that I'd like to see you in 6 weeks to discuss your test results is an artifact of, I didn't have a way to send your test results or discuss them before. And so it's always been an appointment. And that's such a, important and but also like intellectually, like a very, very tricky and interesting problem to solve of like, well, what is the new model? How do we get there? Like, it's clearly not just bringing loads of people in for appointments or doing them on the phone or doing them on video. That doesn't count because that's basically the same. It's a bit like, banks going digital by giving you online banking appointments and like your travel agent giving, Skyscanner doing online travel agent appointments, right? It's just, it wouldn't fly. So those are some of the fun challenges. Is like, what do the new models of care delivery look like? And I think if I had to characterize the last 20 years of digitization in healthcare, and frankly, like where 95% of the energy and attention is going today, it's in how do we digitize the 1904 thing? All the way through to like, there's, all this excitement around ambient scribes. We're going to be bringing something to market. But like, I get deeply worried about us putting that in outpatients. You save 4 minutes from every consultation having to write up the notes. And clinicians love it. It's very game changing, all of that. Question about whether actually that can be converted into more capacity. I have no doubt it can be converted into better quality patient engagement. We will pat ourselves on the back saying, great, we're using technology to improve productivity. And half the appointments don't need to happen. And so we've made like all these appointments that don't need to happen like a bit more productive. Again, whether we can release capacity or not. So like that's the conversation that just doesn't happen, which I find quite difficult. And we're trying to push onto the system. And I think a lot of people realize it. Like most hospital chief execs, if you speak to them and say, hey, do you agree that half the outpatient appointments don't need to happen? They're like, I disagree. I think it's more than half. But it's so hard to change. I was talking to a tech company who did education before. I was like, how do you do in a similar sector, like very, very, very few productivity gains because it's reliant on, a lesson with a teacher with a set number of pupils, just like being reliant on an appointment with a set number of patients. So how do you implement these big changes? And they're like, it's easy, school holidays, right? That everything pauses and so you can implement this stuff. And we don't have that in healthcare. We kind of have the opposite of that, where we don't even have weekends, and even the days we do have are so overstretched that the idea of being able to your point, leapfrog things and completely reset is just so alien to people. And I don't know the answer to that. But I've got some ideas of how you do it, but we definitely haven't proven the answer to.
It's crazy, isn't it? I mean, when you've pulled the thread for so long, and this problem's connected to this problem, and this problem's connected to this problem, and I remember Elliot from a company called Infinity saying this a long time ago that when they try and solve the problem of handover, you're like, right, okay, handover's done on pieces of paper. It's people, meeting in a corridor, their paper might be ripped, they've lost half of it. Okay, let's digitize it. And then you're like, okay, cool, we've now digitized it. But actually, in order to fill the digital handover sheet in, that's actually every task that's happened in the hospital in the last 12 hours. So you need to actually know all of those tasks. Well, actually, some of those tasks are being recorded, some aren't, some are being done and not being crossed off. And before you know it, you're now in a situation where you've got this enormous task management platform for absolutely everything in the hospital, which may or may not be far too cumbersome to actually be used and adopted properly, because it needs to be not only that hospital but across sites, because you've got some clinicians that move across sites. Now you've got a transport issue. Now you've got an interoperability issue between yours and theirs, and you've got to solve that. So all of a sudden, like, everyone just ends up at the same place. You're in health tech for so long, eventually you're just trying to reorganize the entire of healthcare. And just to the point we're trying to make here is like, let's just go to the Middle East and build a new hospital and just start again. Does not solve the problem that we have here.
It's two things. One, Elliot's great, and when I mentioned walking to a hospital nearby and seeing this all outpatient department, I was walking with Elliot. So
were you? Amazing.
He's our general manager for Accurx now, as a part of the team, and
nice.
It's a small world. But yeah, this interconnectedness adds an extra level of complexity, because one of the things that we are working on, and everyone agrees is broken, but it's very hard to fix, is the interface between providers. So how do staff in different services communicate with each other? And at the moment, people in tech say, there's no interoperability in healthcare. Oh, there is interoperability. It's called letters, right? Every single system handles a letter. Every system, every EPR, document management, you put it in a file folder, you can put it in email. It's like the one thing that is entirely interoperable. Other than, you could maybe try and argue copy and paste, but like everything. And the problem with letters, well, the first problem is that everyone's been like, we now do digital letters. It's like, it's still a bloody letter. It's like, I don't make a PDF of a letter. Dear James, thank you for your invitation to join the podcast. I look forward to joining on this date. And post it to you or email it to you as a PDF. And then you scan it in or whatever and view it and code it and say it right. Like, it'd be nuts, right? But that's how it goes. But the challenge with letters, even if you're doing them digitally, is every, let's say, hospital deals with actually thousands of GP practices, especially if it's a teaching hospital, even a GDH, at least hundreds of practices. Each of those practices deals with hundreds of other providers, tens of hospitals, a whole range of community services, school nurses, IAPs, like just this huge range. And all of them deal with medics. So the whole thing's interconnected. So there isn't an ability to say, right, let's just get, even like at ICB level, it's not that neat and tidy, because they'll have a hospital and actually they're taking patients from out of area, and you've got GP practice and you're dealing with patients who are, actually still being treated at this hospital over here because they used to live there or whatever it is, which makes it, again, it's like even harder, but like even more fun to try and solve this interconnectedness problem. And so I spend quite a bit of time actually looking at, well, how did early telephones, credit cards, like all these sort of like network type businesses, industries, like how did they get off the ground? And then obviously the more modern ones, right? The Ubers and Airbnbs and so on, LinkedIn, WhatsApp. Because that's a lot of what we're trying to do, is really like, if I think about the connection, and I genuinely think the communication between services, although at the moment it is the vast minority of the communication on our platform, I think quite quickly it could become just as, if not more valuable than the communicating with patients.
And what's the answer to that? What did you learn when you looked at that? You looked at LinkedIn, WhatsApp, Uber, you looked at these things about how they got off the ground. What are the main things that you learned?
So there's a few things. One is building really tight, really dense atomic networks. So an example would be like when Facebook grew, they were like, let's not just spread really wide. Let's lock it down to like one campus and get everyone on it, and then let's do
Yeah.
another campus and get everyone on it. Same with how a business like Uber or Uber Eats, Deliveroo, any of those sorts of businesses will do. It's like there's no point having restaurants on all over the country. It's like let's get a load of density. And for the restaurant ones, it's even trickier because it's a three-sided. You've got to get restaurants and riders and customers on. So you've got this thing of atomic networks. You've also got this opportunity of host networks. So if you remember how like WhatsApp is so ubiquitous now, we don't think about like sort of its genesis, but initially the host network for WhatsApp was your phone contact book. And so if I had it, it would look through my phone contact book, look at all the numbers, send that to the server, be like, oh, James's number is also on there. James is on WhatsApp, you can contact him. Or James isn't, you can invite him to WhatsApp. LinkedIn, very similar, like scrape all your emails and show this quite annoying nudges that basically force you to send out all these invites without realizing it. But all scraped off your email. Now LinkedIn has the ubiquity that it doesn't need to do that because everyone's on it. So this idea of host networks is very interesting. And that's what we see. We see the GP practice as the host network, because if you think about a complex patient who it has involved in their care, their GP practice, their pharmacy, the renal department, maybe the ED department, geriatrics, a care home, district nursing, like all these services, most of them don't speak to each other, but they all speak to the GP. And we have 98% GP coverage in England. So GPs are like our host network for spreading communication across the system. Now, that makes it sound like it should be easy. It's not. And we are, in terms of atomic networks, we are targeting a couple of ICBs at the moment and saying, right, can we get all of the cross-system communication on there? Because we've made it 2 clicks to message a patient. Like you have a patient up in your EHR, you click a message button, you type your message, and you click send. And there's loads of bells and whistles. You can invite them to book an appointment. You can collect structured data, and you can let them respond. Like do all this much more advanced stuff. But if you just want to tell a patient a thing, you can do it in 2 clicks. I want it to be 3 clicks to message a patient's district nurse to say, oh, when you're out, can you take these obs and let me know how they're doing? Or 3 clicks to for a school nurse to contact a patient's GP saying like, become aware of this and like to discuss it with you, or whatever the example is. And then one of the cool things coming this year as well is, at the moment, all of our communication on our platform is either between a provider and a patient, like a GP practice and a patient, or the gastro department and a patient, or between a provider and a provider, like GP and cardiology as an example. One of the things we're going to unlock this year is the ability to have a conversation between, for example, GP, dermatology, and a patient in the same conversation. So you get in touch with the GP, here's a model. GP brings dermatology into the conversation. Now they're also learning from dermatology. You're all in the same conversation. GP isn't the messenger. Here's directly. Or planning a complex discharge from hospital to bring in GP, the ward they're on, the sort of rapid discharge, discharge to assess team, OT team out in the community, all of that into a conversation. Say, right, what needs to happen? Because I think if we could get every hospital discharge episode into a WhatsApp group and get all the people involved in it, I am so confident you would solve that in a few hours rather than a few days, if not weeks.
And stupid question, Jacob, what is the front end of that? What does that practically look like for those people? Is it literally like a WhatsApp? Is it just a conversation in a text message that we're all used to looking at? Is that what it actually looks like practically?
It's a conversation. We're moving more and more from text messages being the sort of payload of communication to being the notification, if that makes sense. And same with email. Like email is more there for notification, but you actually consume the conversation in a platform. Like when you sign up to Slack, most people don't remember this if they used to Slack because you don't get these, but like you get email notifications. You don't use the email, they bring you into the product to do that. The difference with all of those, and with your WhatsApp and Microsoft Teams and all of these things, like it's built for healthcare. Every conversation is about a patient, not 0 patients, not many patients, but one patient. And there's a structured concept of what are the services, we call them workspace involved, who are the individuals there, and so you can do it in a collaborative way. So if you in that conversation, but actually you go on holiday tomorrow, you're not working tomorrow, one of your colleagues can pick all of that stuff that you need to actually make it work, that doesn't exist today, because we've got this. We've got electronic health records. They are digitizations of what was on paper. They are very, very important. We need somewhere to know what prescriptions does this patient have, what test results do they have. Here are the notes from consultation. They are not built for communication. The gold standard in them, see above conversation, is letters. That's how communication exists in a medical record. Letters are not conversational. They're not threaded. They're not. There is no single source of truth of the conversation. If you're a cardiologist and you're in the hospital and I'm a GP and we're sending each other letters, there is no single source of truth of the conversation. No. I've got a version of the letter I sent to you saved somewhere, and you've got a version of the letter you received from me saved somewhere. There's this massive gap around communication. Then you've got the WhatsApps, the emails, the Microsoft Teams, all the WhatsApp for Doctor apps, all of that stuff. Not built for healthcare, not built for patients as a structured concept. So what that lets you start to do is one of the cool things we can do is aggregate all of that communication with and about a patient into one place, because every conversation is linked to a patient. Like, you can't do that if stuff's in letters and in email and on Microsoft Teams and in a Word document from a handover and an MDT or things like that. And what that means is, one of the things we learn is the act of communicating forces us to summarize. So I'll give you an example. Patients in hospital for a week, and you did this as a doctor. Someone writes a discharge summary and says they came in with this, we did this investigation.
Discharge summaries, yeah.
Exactly, right? You're summarizing a load of data, a load of information into something useful. Same with a referral, right? Here's a whole history, we tried this, and you summarize it. And so if you can capture all of the communication about a patient's care and about their health in one place, that then gives you the most comprehensive view of what's going on with that patient. Because also, if you're a GP, you're not interested in, like, they had paracetamol at 2 a.m. on this day and they had a blood pressure at 8 a.m. of this. Like, you're not interested. No. You want the cream skimmed off the top, and communication forces you to do that. Yeah. So, the headline, normally where I start the conversation with, I just jump straight in. It's like, we see healthcare as a communication industry. It didn't used to be, because you went to see a doctor, they told you what to do. It was a knowledge industry. Now that knowledge is freely available online, as you pointed out earlier. But also, healthcare is so much more complex. So we have all these like super specialties that all need to work together. And again, very hard to, like, if you and I were working on the same team, which is sort of the goal of integrated care, right? Frontline staff and different orgs can work as one team. You and I were working as one team, and the only way we could communicate was dictating a letter that went to the BPO and then came back and had to review it and went to your admin team to work. We'd get nothing done. No. And then I was really urgent. I'll call your switchboard and cross my fingers that maybe you're not busy and we'll follow the bleep. But it's a miracle anything happens. And it happens because staff are so determined and so, deeply professional about not going home until their patients have had the right care. In any other industry, it would just fall apart. And so, that's what we're trying to solve.
And the workarounds mask it as well, because that's what's really interesting. One reflection I've had since leaving is that you can assume that the NHS isn't innovative, and that's in part correct. However, its staff, I have seen some of the most innovative acts of getting around the actual lack of innovation by those human beings. It is wonderful to see how human beings that are so, as you quite rightly point out, that are so determined to do right by their staff and get home at some sort of sensible time will just find a way. And this is what's super interesting. you can pick up. It's funny when you're talking, right? The amount of flashbacks that I have of like all this sorts of stuff, and you like any clinician that's been lot longer than like half their time as an F1 will be able to like look at a stack of notes, and there might be 3 sets of notes completely full, wrapped together with an elastic band, and they'll just know, like, they'll know to like the confidence level of maybe like 2 or 3 pages of exactly where they need to go to get the information that they need, even though there is absolutely nothing discernible about that stack of notes that would indicate where they should actually be going. But they'll just fire in, and like that is already masking a serious issue of being able to search through notes to get the right data, which should quite clearly be a digital issue that had been solved long ago with OCR engines. Like that should easily have been solved. Doctor's handwriting aside with OCR engines, but you see what I mean. Like the innovation of the staff is masking so many of those issues that I guess my question here is, with everything that you like, there's ICBs that you're targeting, right? And this gets in and this starts to really solve this problem. When you actually solve this problem, what does success look like? And I don't mean that in a superficial sense. Like, yes, we save time. Yes, the workforce have less cognitive load. I get it. Those are the more obvious things. But like the second, third, fourth order of things happening here, that people get their time back. What actually happens next? Does care actually get reorganized? Do more questions start being asked? Do we start going more towards a newer version of the way that we set things up? And you and I can't decide what that is right now, maybe, or maybe you can. Maybe you are aiming at something. Like, I'm interested in that second, third, fourth order of things here beyond the yes, we save time and there's less cognitive load. Like, what are you aiming? What are you hoping for in those ICBs? Like, what actually do you think? Maybe not hoping. Like, what do you think is going to happen?
Yeah. So before I get to that, the staff workarounds is just, it's off the charts.
It's amazing, isn't it?
Some of the workarounds are hilarious, but like also that's the reason we exist. When we did antibiotic prescribing, we asked some GPs, what do you do if you see a patient and you think their sore throat is viral and you don't want to give them antibiotics? And they said, I give them a leaflet because then they don't feel like they're leaving empty-handed. On a whim, we were like, okay, we can send that leaflet by SMS. Fast forward 6-9 months, or maybe a year, users, not in big numbers, but started saying like, James, you don't have a sore throat, ignore the advice, but your prescription is ready to collect, because there was no other way to send a message to a patient. And it took us way too long to identify signals like that. And then even when we launched, we thought this was just going to be for sending advice at the end of an appointment.
Yeah.
Come in, you've got some knee pain, you get some NHS choices at the time advice on managing knee pain. That's what we thought. That's like 5% of our usage in general practice now, if that. Most of it is this incredibly broad bucket of other stuff we can get onto. So yeah, definitely agree on the innovation front. And I do think this innovation sometimes hampers the system because you end up with this calcification of fixes to more systemic issues.
Ossifications of these workarounds, yeah, absolutely.
So what does the second, third, fourth order look like? Probably second, third order is we can debate how long it will take, and we can debate who will be the winners. But like, what I think is completely inevitable is that half of what happens, if not more, half of what happens in appointments today will happen asynchronously. It's what we've seen happen in every other sector. It's what the shift we're seeing happen in GP, which opens up loads, saves loads of time. It's way more accessible for patients because, actually most patients can't just take a call at a random point in the day, let alone take half the day off work to go to an appointment. Half the activity that happens today will happen asynchronously through messaging. Care. You won't actually know as a patient what different organisations people work in. You will just have this care team around you that work as one team, which, the system's been talking about integration for longer than I've been alive. But, see above conversation, it's not possible to work as one team if you have to dictate letters to each other. And then the third is, so healthcare will be more asynchronous, more integrated, and then more automated. Now, we've got to be really careful that we don't automate bits of appointments, like the outpatient example earlier. And the nice thing about making things more asynchronous is it lends itself really well to automating. So an example is, I'm a firm believer for as far as I can see into the future, that clinicians will be in the driving seat of making clinical decisions. They should be. And there are actually just some practical reasons why I don't think for at least the next couple of decades algorithms will be making clinical decisions, except in very, very defined guardrailed cases, like classifying radiology images and things like that. I'll probably be wrong because the tech advances so fast, and like some young'uns will come and solve that. But and we can get into why. But I think, but what's actually really valuable is if I come in and like, a history's already been taken, and like there's the relevant information is surfaced, and like that stuff can be automated. I'm going to get back to second order impact, fourth order impact, but as a slight aside, we use something called Intercom for our user support, and everyone in the team spends time on support. I was on support the other week, and one of the big shifts that I've seen over time is there are a lot more conversations. There are a bunch of conversations that are solved by their AI agent now, and it's a user asking for a thing, and it goes through our articles and it goes through all our past conversations. It says this, and that's fine, but those are quite simple ones. What I actually find more interesting is that the conversations it hasn't solved, but where you get to it, you have all the information you need because it said, "What's the problem? Have you tried this?" No, they've tried all the basic stuff, and then that's actually like from a from a human ingenuity and curiosity point of view, much more meaningful work. As in, I've solved this, it's not just this, really, really simple problem that, you can go through a process flow and do. I actually have to try, do some bit of detective work to work out what's going on and what, maybe there's a bit of user feedback here I want to pass on to the product team. And like we want to liberate people to do that work, not just in our support team, but also like clinicians. So, and there are some challenges around that we can discuss. So more asynchronous, more integrated, more automated. I think that then the fourth order, what comes after that is setting goals with patients and then helping them achieve that. And I think that gets lost in a world where there's ambulance queues outside A&E and there's 10-minute appointments and all this demand and things like that. But if you think about it as that's a very human endeavor. It's like requires empathy, it requires trust, it requires building relationships, it requires continuity. And like I want people to have to be able to spend time on that, and then all the actions that come out of that to for them to be have a much higher chance of success. If that's like managing someone's type 2 diabetes, we know really well how to do that. There's like systematic reviews on how to manage type 2 diabetes well. And it's really simple stuff, like get your feet checked, get your kidneys checked, get your eyes checked, and only 50% of patients get it. So like we need to automate that stuff so that we can free up people to do the more human part. The other part of the other third, fourth order part, specifically on the asynchronous piece and to an extent the others, but in the short term, particularly the asynchronous pieces. Have you heard of Baumol's cost disease?
No.
So he was this economist who, I don't know when it was, probably in the 70s, observed that when Vivaldi wrote a piece of music, it took, for a string quartet, it took 4 musicians. And today, if you want to play a piece of Vivaldi music, that same piece of music, it takes 4 musicians. And there have been 0 productivity gains. And meanwhile, if you look at how many, person hours it takes to grow 100,000 calories, or to, ship goods from this side of the world to the other, or to, manufacture a vehicle or build a house or whatever, like all of the, there are huge productivity gains because of things like mechanization, technology. And those push up wages in the economy across all sectors. And so the things that don't have productivity gains get disproportionately more expensive. So hairdressing, musicians, teachers, doctors, because a 10-minute appointment with a doctor always has and always will take 10 minutes of a doctor's time. Why do I go on that little tangent? Well, it's because we're not going to get 10-minute appointments down to 9-minute appointments.
Yeah.
But if we can actually get that down to 1 minute of a clinician's time, because they're messaging and they can just review what a patient sent. Classic example: the patient has a rash on their arm. 7 years ago, they'd have a GP appointment to look at it. Today, they send a photo, GP looks at it, and let's say they need some topical steroids. They send a prescription to the pharmacy and tell the patient, without ever picking up the phone or seeing the patient. And so what would have been a 10-minute appointment is 1.5 minutes of a clinician's time. That's where productivity gains are going to come from. And if we don't do that, healthcare is just going to become more and more unaffordable. And that sort of every economy in the world is struggling with this. In part for good reasons, like the better we get at medicine, the more expensive the treatments get, the longer people live with more conditions, and I think everyone knows that part well. But this lack of productivity growth is incredibly existential to modern medicine.
Whereabouts are you guys at with this right now? Because this is a problem that I've heard it since I was a clinic. I've been hearing this for 15 years that, if only we could talk to the hospital down the road, in various forms, right? If only we could talk to the hospital down the road. If only the notes from there were here. If only everything was done on a computer. If only I could just message the blah, blah, blah. If I could see all the stuff in one place. So many people have tried this from so many different angles, seemingly. And whatever it is, whether it's in part timing, whether it's in part, I don't know, whatever the various things are, if it seems to be aligning for you to the point where you're now, focused on a couple of ICBs and actually starting to do this, something's clicked. Is it the way that you have done it? Is it something else? Like, why has this worked? Whereabouts are you with it? And I guess, what's the timeline here? And is this actually going to happen? Are we going to see this?
So it has to happen. These things always take far longer than you'd like. What I find very funny is that people like sending out communication. In general, people don't like receiving communication because it is a proxy for work.
That's why I do so many podcasts. No one listens to
them. When you ask people, Satya, our VP Clinical, is fantastic about this. When you get people, but we do, it's another channel, and we're going to get more of the inbound. We're going to get work done. Things like, is the way you deliver care now the way you want to be working in 5 years' time? Pick a timeline. And obviously the answer is no. And it's like, right, well, this is the first step. And like with every change that's worth doing, there's going to be some pain and teething issues. And actually half of them is that you've got to check 2 places because you're still getting your letters coming in and all of that. But we don't have a choice. So we're focusing on through ICBs and proving out that sort of critical mass of communication. We're looking at, what are the sort of 10x features that are, this isn't just a bit better than a letter. This is game-changingly better because I can have that 3-way conversation I mentioned earlier, or I don't actually even have to write the message. It's ambiently written off the back of the conversation we've just transcribed. Or when I see that communication, I not just see a snapshot of, but I have access to that patient's GP record. What are the 10x features is a thing we're experimenting with. Another one's having a really, really fantastic directory, so you can very quickly find the cardiology advice and guidance or the district nursing service for that area. It's amazing how when we show the directory to GPs in an area and they've been working in that area for 20 years, they're like, I didn't even realise we had this substance abuse service for 18 to 25-year-olds or whatever the thing is. I don't know if I've really answered the question. It's we've got to do it. It's getting there. We do about 100,000 conversations between between healthcare professionals a week.
Wow.
But we do about 10 million between healthcare professionals and patients a week. So it's like, there's still a very long way to go.
Yeah.
About 5 million of those are sort of more like are richer than just the automated stuff or batch stuff. 6 million. So yeah, we've got to solve it, because all of this, with this whole integration thing, the shift from hospital to community, the shift from treatment to prevention, it's not going to happen. Even all this effort on population health management, absolutely the right thing to do. But if you say, okay, great, here are the 100 patients at most at risk of having a fall or most at risk of hospital admission, then what? Send them a letter? Send their GPs a letter?
Yeah.
There needs to be an easy way to drive action off the back of it. And I think one of the things that's got lost because of this, constant pursuit of local optima has been, okay, everyone needs to be able to see shared care records. Yes, that is valuable. But if I'm a cardiologist and I can see your GP records, that's important, that's useful. But the second I need to talk to your GP, I'm back to dictating a letter. We haven't solved it.
It's not root cause.
And the reality is with the shared care record stuff, it's in theory they're there and the box is ticked. But whenever I speak to frontline doctors, how's that? They're like, when I do this locum shift, I don't have access to it, and there's a smart card we pass around A&E, or it doesn't work for out of area patients. We're a specialist hospital, we have loads of out of area patients, or the data's delayed by however long, or I can't see any of the letters, I can only see a medication, or whatever the thing is. It hasn't been solved. So yeah, there's a lot to do. A lot of work to do.
There is. And just coming back to something that you said towards the beginning, that it's fun to solve. And that's an interesting concept of when you come across something difficult. It's funny, it's happened a few times in this conversation even, that when you talk about the really difficult thing, you start to smile a little bit. And it's it's interesting. It's this it's perverse. It's like masochism of entrepreneurs that they, once they come across the hard bit, it's yeah, right, now we're going to feel some pain. But when we're through it, we're the ones that are through it. And actually, I know that other people are going to fall at this hurdle. And that seems to have been what's happened in solving this communication issue, because this road is littered with so many skeletons, so many investor dollars, so many founders that have tried to do this, that actually you seem to be getting through these gates. And it's interesting to me because you're coming across these little things or seemingly little things that are the big things, like the quality of the directory. That is a hurdle that if you get that wrong, all of a sudden this entire system doesn't work, because it takes ever so slightly, and it could be milliseconds, this ever so slightly too long or slightly more cognitive load because the loading time's a bit too long. And all of a sudden, 100%. The directory is no longer useful, and that the whole value, it's like an upside down pyramid, is just resting on this tiny millisecond change of loading time on a thing. And it's funny because I don't think it's an accident that you just said, these phrases that, if you're listening to this podcast, you might have just missed. We all spend time on life support. And it's I was on life support the other week. And it's funny because you also said at the start of this podcast, I wrote it down, that you want to spend an irrational amount of time with your users, and it still keeps you up at night that you're not. And it's funny how all of this seems to come together. This obsession with users, this obsession with I'm going to put myself in their position, and this obsession with I'm going to learn what it's actually like, and I'm going to solve these problems. And so the loading time of the directory, I'm going to come down on this team really hard to make sure this actually works, because I know that every piece of value downstream is stood up on this tiny thing, which others might just skip over and say, it's fine, there's loads of value, of course they'll wait. No, they actually won't. They actually won't. Trust me, they won't. And so it's interesting that you've still got that fire. You've still got the smirk across your face when something's hard, because I think you've just found a system and a way to solve those types of problems. And I think that answer is just be obsessive about users, if that's a fair pop psychology of what's going on here.
We should come back to it, but I'd say we've been on a journey where I think we lost some of that and then we brought
Interesting.
it back. But a couple of things. So yes, absolutely, we've got to spend loads of time on our users. I think that's one of the reasons why healthcare is so behind on technology, because you have a load of staff who see the problems but don't know what's possible with technology or don't feel empowered to change things, and you have a load of technologists who are just unaware of all these problems.
Say this all the time. Computer scientists need to do water rounds. I say this all the time.
Yeah, exactly. And that's where where I was 10 years ago is basically is just starting to realize, before starting Accurx, like, oh wow, there are all these unsolved problems. The point on solving hard problems is fun. I don't think that's just a founder thing. I think it actually goes back to what we were when we were talking about automation. Like, I don't think most, for example, GPs get loads of satisfaction from seeing a patient with hay fever who can take some over-the-counter medication or pick some other, or not even self-limiting stuff, but just they're following a protocol that's quite straightforward, especially if the patient is an engaged patient, things like that. I think the rewarding part is where we've got to do hard things. I think
I just watched a 90-second video on my stupid phone about a guy unblocking a drain. And when he unblocks the drain and this thing is just singing, this thing is just hosing water at full diameter, I'm like, that's just great. Like, yes, we like to see problems solved. I completely agree.
Yeah. And the harder the problem, the more satisfying it is. So I don't think it's just a founder thing. I think maybe what you then get in founders is the tolerance to endure pain in solving the problem is possibly higher. And the risk appetite, higher. But yeah, it's got to be fun, because these are hard problems, and if they're not fun, then you sort of pack up pretty quickly. And if they're not rewarding, it's incredibly rewarding to hear from users that they were going to leave their job because it was so stressful, and now they actually have time back in their day. They've stayed in their job and they can see their kids in the evening. That's incredibly rewarding. And many other of those sorts of examples. But the thing I'm actually proudest of, we were talking about it our last one. I think we'll turn 9 in May as a company, but when we turned 8 last year, I was talking to the team about what I'm proudest of, and it's if Accurx ceased to exist tomorrow, and we just pulled all of our software, shut down our servers, pulled all our software off computers, there is no going back. General practice, the way care is delivered, has changed, and there's a whole queue of competitors that will deliver it in that will provide the technology. But more important than the technology, there are 6,500 practices in England out there, and more in Scotland, Wales, Northern Ireland, who run differently now than they did before us, and who aren't going back. And that's that we've actually changed how healthcare is delivered in general practice. Now, there's so much work to do, even just in general practice. If I look at the practices who really moved the needle, the total triage practices, that's coming up to 1,000 practices in the country. It's 15% of the practices. There's still so much more to do to make that the mainstream, and then to go even further in those practices. But even in all of those 6,500 practices, they have changed how they deliver care. Their care is more accessible. They are more productive. When you look at GP practices over the last 5-6 years, they're doing more activity with a smaller workforce, and in hospital it's the complete opposite trend. Way bigger workforce and less activity, and that's the thing I'm most proud of. But I do feel like we're just scratching the surface, partly because this whole reset alluded to, we're just, it's day one, we're just getting started in what we're doing.
You mentioned the journey of losing that, I guess, customer centricity, if you want to call it that, and then coming back to it. What was that journey?
What's the short version of this. I wouldn't just say it was customer centricity. I would think it was just losing our way a bit. I
Right.
think we grew incredibly fast in lots of dimensions. The size of the team, the scale of our usage, our revenue, like lots and lots of different things in a short space of time. And I wasn't intentional enough about that culture, and lots of things I took for granted, like us going spending time with users, being one of many examples. And culturally, we tried to kind of be everything to everyone.
Sure.
And that then started to decay. And when you try and make everyone happy, you make no one happy. And so it got to a point about 2 years ago where I'd clearly become a bit of a pain to work with and had that feedback, and was very frustrated with lots of things, but sort of frustrated at, I don't know who, but like not myself. Of, with my coach getting to the point of, hang on a sec, this is like, I've got us to this point and I've got to fix it. No one else is going to. And so over the past 2 years, 18 months, reset just about everything. So the strategy, kind of multiple times, the org structure, the whole leadership team, the culture, a lot of the, then the functions within the company, how we approach doing product, how we approach go-to-market, like just about everything, which is incredibly painful. Lots of, just really painful for lots of people in the company. Like this thing that they were used to doing and they thought was good is like suddenly changed. People that were used to working with and friends with have left. But now I feel like last time we spoke 6 years ago of like, wake up and like try to get into work as fast as possible. Like, what problems are we going to solve today? And like, how do we move the needle on this today, not in 2 weeks' time? We started to. There's this fantastic interview with it's called The Lost Interview with Steve Jobs. It was lost because someone recorded it and lost it and then found it in a garage like 10 years ago or something like that. And it's in his wilderness years before he comes back to Apple, and he talks about where most companies lose their way. And where most companies lose their way, he says, is they have some early success, they want to replicate that success, and they think that what got them there was the process. They put in place all this process for success. But it was never the process that got them there, it was the content. And when I realized this, I looked at everything we were doing, and doing great work had become following the process rather than the content, the outcome. So, rather than, it might be, here's a design we're going to build. We follow the process really well of like how we reviewed it and researched it with the user, rather than like, but is it a brilliant design?
Yeah.
Like, is it like, use your taste, use your intuition, use your judgment. Like, is it going to move the needle? We're gonna, hire this person. They passed all their interviews. Like, but are they gonna raise the bar and bring that energy and that fire for the mission? And like literally everything. And I was like the most guilty person of this, of like, putting a lot, because you have to put in process as you scale. And this has been misunderstood a bit internally of like, Jacob hates process. No, process is important. The content is far more important. Right? So it's a lot of this sort of reset, a big reset around urgency. So when we wrote down our values 8 years ago, we never wrote down anything about urgency, speed, pace. Right. It turns out that was actually one of our biggest advantages, is we just move fast, often in the wrong direction, but we just move fast. But we didn't realize it, and so we never wrote it down or tried to protect it. And so we had to bring that back in, and so we've got this value, this principle I'm moving with urgency now. And the question I ask, and I want everyone on the team asking, is why not today? It's like, James, okay, we need to, off the back of the podcast, let's follow up this thing, discuss that thing or whatever it is. Oh yeah, we can make some time in 2 weeks. Oh, I'm actually away then. What about
I hate the let's catch up. Let's catch up. Yeah. That message that you get from, oh my God, let's catch up. Okay. Yeah.
So there's been a lot of this just being much more intentional about our culture.
Yeah.
Like the first principle is fix healthcare communications. It's a very, very simple acid test of, okay, should we like do this, put in place this random company policy or like prioritize this feature? Or like, will it fix healthcare communication? Oh yeah, it gets us there. Okay, cool, let's do it. Or it's a bit tenuous. No, probably shouldn't be doing it then. So it's been quite a lot. It's been very painful resetting that, but it's been very rewarding because now just the energy and caliber of work the energy in the team and the caliber of work we're producing is something I am and we should all be really, really proud of. But I probably lost us about 2 years, the company, by having the wrong strategy and the wrong org structure, and knowing in my head, oh, actually it should be that, but not having the courage to change it, and doing that too late. And so fortunately we're commercial, as a business financially we're in a position where we could go get through that.
Yeah.
But yeah, I've learned a lot.
Well, I love that for you, man. I think that's awesome. It is painful. Like that must be horrendously painful to have to go through that. And it's a strange one, isn't it? Because what got you somewhere not being the thing that gets you to the next stage, that's a hard thing to learn, because those things are what got you there. And knowing which are the bits, you're going to have to do this process of going, well, how do I know that it wasn't these things and it was these things? And you're going to have to find that out. And then you're going to have to look at yourself, and then you're going to have to come to terms with it, because then you've got a big job on your hands that you have to work yourself up into, and then obviously executing that. I mean, this is a very, very difficult thing to do. So to say you lost 2 years is quite interesting. I think you've landed a lot on yourself there. I've lost 2 years to the of the company. It's probably not as straightforward as that, because of everything that you probably gained in the run up. Like those instinctive decisions that you made in the run up have put you way ahead. And you had 2 years to lose, frankly, because you're still in the position that you're in, which I think is an interesting concept.
I think that's a very. I mean, it's a very generous framing, and it's not to downplay. Like we have still had wins in those 2 years. And like the team has produced some great work and some great features and more success in the market in those 2 years. But we are catching up on investments we should have made a couple of years ago. So one of the things is we. I keep saying we, but like I'm responsible for this stuff, right? It's our org structure. We split into GPs and hospitals. Now, it turns out if you're trying to break down silos in the health system, having those silos in the company is not that
interesting.
productive. And I kind of knew this intuitively, but didn't act on it because we built so fast in 2018, 19, 20. Half of 21, we accrued a lot of tech debt, but also a lot of duplication. So one of the big shifts in our strategy in mid 23 was we have one product. We're not going to have all these point solutions. Got to the point where we had, for composing a message, if you think about, we're a communication product, so like the bread and butter of the product is composing a message. I think we had 15 different experiences or parts of the product for composing a message. And like for very rational reasons, for like a team is working on a thing and they're like, what's the quickest thing to do? Right, branch the code and then go build this version.
Right.
Now, it's impossible to make any of them great when you have more than one. And it was one of those things where it's like, oh, James, we've got 15 composers, and you're like, oh, does it include this one? And like, oh no, we've got 16. Like, you don't even know how many there are. And so a massive lift in product and engineering and design has been convergence and saying, okay, there's one compose capability, there's one conversations capability, there's one inbox navigation capability, there's one content capability, the templates and all of that. And it's also meant that we haven't shipped loads of new features in the last year because we've been so focused on this convergence stuff. So I'm very, very confident it will speed us up in actually not even the long term. Like we're already starting to see the results of like we build a thing here and then immediately we get all of this benefit rather than like just this benefit. But we should have done that 2 years earlier. That's on me. That's on me. But fortunately, we've been able to correct that. And it's so exciting. Like the stuff the team are building now, we moved from having teams that would be product teams that would be tied to a market. And so, once we work on 6-week cycles, one cycle they work on this, and then they jump over to work on that, but with a bit of this thing that's still overrun. And then to now, every product team owns a capability, and they're like, how do we make this the best directory in healthcare, the best inbox in healthcare? Which you can only do if you've got that just complete dedication to that
focus,
that
absolutely.
So yes, it's lots of fun. And the same in the markets too as well. We got to the point where we had people spread across doing a bit of acute trust and a bit of community and mental health, or doing a bit of GP and doing a bit of pharmacy and a bit of the interface between them. We said no, we need general managers with a total focus on that market who can immerse themselves. Really, we got very stuck in like trying to sell features and really push it to selling this new way of delivering healthcare. Features are features, but like actually we're kind of selling productivity, right? It's like this is a new way to deliver outpatient care or to run mental health services or things like that, which is a massive shift. Health systems not used to buying or thinking about that. It often puts technology in this digitization bucket because that's historically what technology has done, digitize stuff. But that's the shift we're trying to make in the system.
Yes, one of the things you mentioned there was pharmacies as well. You've wasn't hard enough just doing GPs and hospitals. You've decided you've kept pulling the thread, and pharmacies are now at the other end of the thread. So, yeah, what's going on?
So I'd go further than that. So doing pharmacies, but also high street optometrists and community MSK providers and talking therapy service. And like, I think the system is very quick to be like, well, the health system is GP practices and hospitals and maybe district nursing, maybe mental health, but actually it's so many services in so many organizations. And the government talks about hospital to community shift like that. This is a very good example of it. In pharmacies specifically, it's a lot of the same stuff. This is, again, going back to the convergence. The learning has been, we used to treat them as needing completely different products. But it is, now we need to package them differently because the services a pharmacy delivers is different. But, the most basic is messaging patients. So pharmacies need to tell patients that their prescription's ready to collect, as an example. But then you get into more interesting and advanced things like lots of pharmacies doing more clinical services.
Well, this is what I was wondering,
Yeah, so really simple example, you're doing travel IMS. You can send out questions to say, questionnaire to say, where are you going, when are you going? And then off the back of that, what IMS a patient's likely to lead, or doing combined oral contraceptive pill checks or managing UTIs or things like that. Then there's a whole piece around communication with other providers, obviously particularly the GP. And it's another great reminder that whenever people, health leaders, consultants get in a room and map stuff out, they make these nice process flows of like patient comes in the ED front door and then this, or patient goes to the GP and then they get referred and then this nice, beautiful, linear pathway. And the reality is, it never, ever, ever works like that, and it's all a massive mess. So, like a really nice example of what that would look like. Patient gets prescribed a thing, go to the GP to get a prescription. Like that would be the process flow. But actually, what happens is they go to the GP. The GP's like, we actually don't have this medication in stock, but we do have the same medication at half the dose. So now I need to contact your GP practice to say, can you reissue the same prescription for double the quantity at half the dose, right? Very, very sort of, very,
very
that
real,
sort of thing is very
life.
common.
Yeah.
Very, very real life. And like that is the mess of healthcare. And so it's a thing I struggle with a lot. When we struggle with a lot when talking to the system, because they're like, well, what's the use case? And I compare it to like we've just invented the telephone and we're going to tell us it's like, what do you use it for? It's like, well, like everything, like solving any sort of problem. And so that's where I think most of the value is going to sit. And I can't point at like, oh yeah, I can give the example of the travel vax or the pull check, whatever. But the biggest value is just going to be you can talk to each other. So those are some examples in pharmacy. One of the other big things, there's some really exciting big bets coming this year. One of them is it links into pharmacy is the health system has spent the last at least a decade, probably closer to 2 decades than 1 decade, commissioning all of these other services in the community as an alternative to going to your GP or going to the ED. Self-refer, physio, audiology, podiatry, pharmacy first, minor eye casualty service, like all this stuff. Most patients don't know it's there. Lots of GPs don't even know it's there. But it's worse than that. When patients go to their GP, quite often, contact their GP. The easiest thing is just for the GP to deal with them, and so the patients never find these services, and so the system resorts to things like, let's put ads on the back of buses to tell patients to go to the pharmacy. Yeah. It's like when if I'm unwell, I don't go around looking at buses to see. Like I just contact the GP. I realised how ingrained this was when. Our youngest kid is completely obsessed with nursery rhymes, and when he's like learning like Miss Polly had a dolly who was 666, she called for the doctor to come quickly. It's like it's ingrained from before he can even talk, and he's like humming nursery rhymes. We're teaching society, you have a health problem, go to the doctor. Patients are wired to go to their GP. So with our digital front door, what we're doing is intercepting the patient on the way to contact their GP. Not giving a sort of triage recommendation or a differential diagnosis, because the problem is, one, if you tell a patient to self-manage, they'll just be like, well, now I want to speak to a human and hear it from them. But two, there will be a conversation with a clinical safety lead that says, right, now we get to configure the algorithm. Do you want to make this really efficient or really defensive? And obviously the decision will be really defensive, because healthcare is, for quite good reasons, often optimizes for minimizing risk, also for some bad reasons. And so you'll end up with a 1-1-1 problem, which is everyone goes to A&E. And so the approach we're taking is saying, okay, well, based on what you're saying, using some AI, you've got back pain. In your area, these are the 5 services to manage back pain. As a patient, you decide. You can go and watch some videos of exercises to do. You can use this MSK app we've got. You can self-refer to physio. You can go to the pharmacy and get some medication to help with the pain. Or you can contact your GP. You decide. That's the approach we take. And then you can get into all sorts of nudges to, you go to the pharmacy, you don't have to wait. You can do self-management. You can access these resources 24/7. You can do all sorts of clever nudges. But crucially, meet the patients where they are. And that includes, if they're calling up, receptionists being able to say, would you like me to send you some exercise you can do for your back pain? Did you know you can refer yourself to physiotherapy? I can help you do that now. So that's one of the things I'm really excited about this year. And then you can see how that quite quickly grows legs and is extensible. Yeah. So if you come in as a patient with IBD who's having a flare, actually the top option is contact the CNSs in the gastro department, or you're under maternity or whatever the example is. And this is again where you start to join everything up, because the big learning, the total triage model in general practice is completely game changing. It's like eerie when you go to practice doing it, because the waiting room is empty and patients, you're seeing the responses get, the stuff patients send in getting resolved, responded to within 15 minutes. And when a patient needs to be seen, they're being seen the same day. But actually we've realized it's exactly the same in outpatients. It's basically moving from a capacity-led model of these are the appointments we have, form an orderly queue, everything's appointments, to, and that's how you end up with 7.5 million open pathways on a waiting list, to let's surface all the demands. And I mean like all of it, which is nerve-wracking for clinicians, understandably, And then what we can do, we're going to triage it and we'll work out. And it turns out loads of it, actually is administrative and doesn't even need to hit a clinician. Loads is self-limiting. Loads of it can be resolved asynchronously. Some of it's really, really important and urgent, and we can bring it way forward rather than it just sort of languishing or ending up deteriorating, and a patient, ends up getting a late-stage cancer diagnosis, or whatever the example is. And so that's, if I look at some of the work we're doing in outpatients, it's all about taking those learnings from general practice, surface all the demand and triage it, rather than this very bizarre model of I'll see you again in 6 months, whether you need it or not. And if you need it any sooner, sort of go to A&E maybe. And if you don't need that appointment in 6 months, whatever you do, do not DNA, because it costs the NHS £160. But that's how we run outpatients. So there's a few things to keep us busy.
It's a true reorganisation of care, isn't it? And this is the thing that we've all had on our minds for so many years, which is that we know that this is not right. We know that not everyone needs this level, and some need more, some need less, most need less. And we've all known this for so long. And any conversation about reorganising care, you've seen it in in GP practice, you might set up a clinic with a prescribing pharmacist. You might set up a clinic with this, but it's it still requires that kind of that triaging component. And it's actually like what you're saying is instead of just going just try setting up a clinic of blah, you're actually let's just surface absolutely everything, but now let's also get absolutely all of the potential services and do that at scale. So rather than landing it with, that GP practice to try and reorganise care bit by bit, clinic by clinic, setting it up bit by bit. I guess what you're saying is at that kind of level and just scaling that up, let's surface all the demand, let's surface all of the potential services, and we will do the heavy lifting of then just distributing that. And that's, I guess, why it works at regional level.
Yeah. And triaging it. It all comes down to working out, the right... So I'm a big believer in, and actually tried to put this in culturally in the company, of embracing constraints and solving problems by taking things away. Because generally as a system, the way we solve things is add more services, more roles, and more systems, not taking things away. And it's really interesting when you look at unplanned hospital admissions over the last 10 years, the graph goes up massively. When you look at total number of bed days in hospitals over the last 10 years, is completely flat. Why is it flat? Well, because there's a constraint. There are only so many beds. And so what that constraint does is it forces a productivity gain, which is reduced length of stay. And so length of stay has gone down massively over the last decade for lots and lots of different initiatives anyway, we won't get to that. The outpatients hasn't had that. There's no constraint because the calendar goes on forever into the future. And so there's been no forcing function to increase productivity. And so one of my quite strong views now is, well, if you surface all the demand, that is a forcing function to take away low-value encounters. But if you don't surface all the demand, you can keep going with them because you just keep filling stuff in the calendar out, years and years.
Absolutely. Before I let you go, mate, AI, just so I've said it, just so we can just say something so that the haters won't have a go. You're a big name in health tech, mate. What are your thoughts on AI?
It's a technology just like object-oriented programming is a technology. It's a thing that, it's going to have more impact than that. But I guess the point I'm trying to make is right now, there's a massive risk. I think it's already happening that the tail is wagging the dog, and the system's AI, find me a problem, rather than what are the problems we need to solve, which are we have we have stagnant productivity, we have a workforce shortage, we have really high health inequity, we have high barriers to access, we have clinician burnout, we have we can keep going on that list, and then it's how do I solve those problems? And I'm certain AI will be part of many of the solutions there. But I do have a worry of hitting local maximus, like that example I spoke about earlier. Right, let's get everyone using ambient scribes. Great, definitely. Obviously, it's the thing we need to do. We're bringing something out in that space, but we've got to be really careful we don't cement in or sort of that ossification of other layers of inefficiency, of like streamline the outpatient appointment that didn't need to happen.
Yes.
So
Yes.
that's how I think
And
about
something
it.
you said earlier, actually, that, synthesizing lots of information to form a decent bit of communication from one person to another is incredibly valuable. And that is a skill, and that is something that people need to learn. And I know you and I were both at the Heidi event where they talked about this, but yeah, the notion that, or someone asked the question anyway, of what do we lose when people stop doing that? What do we lose out of training? What do we lose out of people becoming expert communicators in healthcare? And actually, is that something that we need to be mindful of? And it is something that I know the ambient scribe companies are researching. And, I know Dom from Tortoise is doing it and really looking at this academically of like, how does, up to what degree does the tail end up wagging the dog in that scenario? And actually, is some tail wagging some dog okay? Do we want dog wagging tail? Like, it's a question. It's interesting, and then you're like, well, if there is a bit of tail wagging dog and dog wagging tail, well, what room is the dog in, and is the dog eating, and is the dog? Like, there's other questions that come out of it, like, is it a better dog?
Yeah, so I definitely, the whole challenge of unintended consequences we need to plan for. It's not a reason to sort of be a techno pessimist and not do things, but it's like okay, how do we solve this, for example, like training challenge of actually taking a good history as part of learning to become a doctor, as part of training. It's part of the thought process of working through a differential. It's really interesting with patients often complain, I've got to tell my story to so many times to different people. It's like, but actually that's quite a valuable part of the encounter of that clinician working through their differential and building rapport with the patient and having the chance to think and process it that you wouldn't necessarily get if you just read what was recorded that someone else read. Obviously, there are lots of cases where actually a lot of that can be streamlined, so it's not as straightforward as that. But the human facts of it is the most interesting part. But I'm really interested in, like I mentioned, this outpatient piece. Who needs an appointment? Like, why don't we point AI at that problem rather than streamlining the points that happen? One of the reasons the ambient scribe thing works quite nicely is it's a simple intervention that can be applied by one user in one consultation with zero other process change around them. And there's a lot to be said for that, because see above conversation about complex system. But it's also very human in the loop. Like there and then I'm reading my summary and I can see, is it an accurate representation or not? Whereas even something as sort of seemingly simple, like summarizing a medical record and give a summary, I don't know if that summary is accurate unless I read through the whole medical record. So that's how I'm thinking about it. Lots of opportunities with AI, but got to focus on the problems first, and get the human bit right. Spending lots of time on the front line and seeing how things work. So yeah.
Agreed, mate. Well, Jacob, listen, it's been a pleasure. Thank you. I guess get you on in another 6 years. You still going to be in health tech another 6 years? I guess we'll see.
Absolutely. Somebody said, "What's your exit strategy?" I said, "Death." So, of me, not the company, I should clarify.
Failure is an exit, as they say. Yeah.
So, hopefully sooner than that. But no, I've really enjoyed it. Really nice to catch up, and I hope if we can have as much progress as the last 6 years, that'll be a lot of fun.
Sounds good, mate. We'll see you then.